All right, so today I thought we would talk about some non-obstetric surgery during pregnancy. It comes up often. In this article, I sent you the article that was in my board review this year. I thought it was pretty timely because I get asked all the time about different issues as far as imaging and timing of surgery and stuff like this. And this was a recent article that was put out as a review article in the Green Journal. And I thought it was a pretty good thing to review because this is something you guys will get in your practice, even if you're not going to do OB. Remember, 1 to 2% of all pregnancies are affected by surgery during pregnancy. So it's a pretty common thing to see. It's not like it's a rare event. And of those, not surprisingly, 45% of the surgeries that occur are GI related, and most of those are appendectomies and cholecystectomies, as you know. 24% of the overall is orthopedic and usually due to trauma. And the biggest issue that always comes up is the reluctance to operate on pregnant patients, especially early on in the first trimester. In the past, it's always been said, first trimester, if you operate, you're going to cause more miscarriages. Second trimester is the ideal trimester. And if you wait till the third trimester, people are concerned about preterm labor and delivery. So this article does a pretty good job of reviewing the myths and the urban legends surrounding non-OB surgery. The thing that's important to understand is a lot of the studies are old. They were poorly controlled studies. They were done at a time when imaging was different. There's a lot of things that have changed, and unfortunately, nobody's really repeated or done the studies to reevaluate the safety in surgery. So this article did a pretty good job of looking back at what's available in the literature and what makes scientific sense and how imaging modalities changed significantly in the past. The other thing that's the problem is they wind up combining these meta-analysis. A lot of times look at all surgeries that occur during pregnancy. And as we know, orthopedic surgery may be totally different than intra-abdominal surgery, which may be different from someone who has an acute appendicitis. And a lot of them don't contain the pregnancy outcomes. They basically are more focused on the surgical aspect and how well the pregnant patient does in surgery. And very few of them actually use pregnancy outcomes as their primary outcome. That is understandable because obviously you can't really do a control group. How do you control for complications in pregnancy? Usually, if you're going to operate on a patient who's pregnant, it's an urgent issue. Most people don't have elective surgeries during pregnancy unless it's very superficial or cosmetic or whatever. But even then, most of the time, it's usually an urgent type surgery. So it's the underlying problem, like the ruptured appendix or the acute cholecystitis, that actually leads to the complications of pregnancy and not surgery themselves, which is also interesting because it's the delay in treatment of these patients that typically lead to more complications, because we have very reluctant surgeons who don't want to operate on pregnant women. So as a result, they wait until they're sicker, they wait until there's no other option. And if we would actually operate on them sooner or earlier, a lot of times some of the complications may be able to be reduced. It is important to remember an ultrasound and MRI is safe in all gestational ages, including the first trimester. This is important recently because for like appendectomy or appendicitis, MRIs are being used much more frequently now to diagnose appendicitis, especially during pregnancy. And those certainly can be done at all gestational ages. Remember, the concerns with ionizing radiation is there's teratogenesis and cause of birth defects. And the bigger concern too is fetal CNS injury. Usually takes high doses, and it's pretty specific to the gestational age of exposure. Now, when we get into dosimetry, which is basically looking at how much radiation exposure the fetus is exposed to, there's two different kinds of effects that the radiation can have on the baby. The first one is called a deterministic effect, and these are basically multicellular type of effects on the baby that leads in malformations, growth restriction due to placental damage, intellectual disability due to central nervous system damage, microcephaly, which is probably also related to the central nervous system damage, because remember, the microcephaly is a lot of times due to small brain or poor brain development. I know we've been seeing a lot of microcephaly lately. It's been just overwhelming how many babies now have microcephaly, not to the degree of the Zika virus, but it makes you really wonder if some of the microcephaly may not be due to COVID, and does COVID really have more of a developmental issue in pregnant women than we really know. Currently, there's no correlation with microcephaly. The patients I see with microcephaly, most of them are not COVID positive or do not have a COVID positive test, but it's just really interesting that we're seeing this huge uptake of microcephaly, even using our new growth tables. Ultimately, it can lead to fetal death, probably once again due to multi-organ failure or due to placental insufficiency. And remember, this is due to damage caused by multiple cells. The other type of damage that you'll see is called a stochastic effect. And this is basically when it's done, the damage is done in a single cell that can then become cancerous. And so this is believed to be related to carcinogenesis. Now, usually when we're looking at early pregnancies, or there was a phenomenon called all or none phenomenon. Back when I was in training, we were using centigray. So 1 centigray was 1 rad. Now the standard is milligray, which is 10 centigray, which is 1 rad. So it's just kind of weird. So why they changed, I'm not sure. But this study basically quotes everything in milligray and versus rads. So I put the rads in parentheses because a lot of dosimetry is still reported in rads. When we're talking high dosage, 50 to 100 milligray, as you'll see, I have a table later on out of the article, is a very high dose for radiation when you start seeing how much you're exposed to with an actual chest x-ray, etc. Now, if there's high dosage exposure or 20 rads, so if you look at that, what I'm basically saying is, if you have a baby early on that's exposed in the first couple weeks after conception to 50 to 100 milligray, basically the baby will either abort or there'll be no effect. And they're not exactly sure why there's no effect, but it's basically the cells are receptive to the radiation and get basically wiped out, or there's no effect on the fetus at all. So that's the all or none phenomenon in the first 2 weeks after conception. Now, the interesting thing is a lot of babies that are 2 weeks after conception aren't even known to have conceived. So obviously the studies are pretty limited because most people don't do pregnancy tests until their first missed period, which you're going to be at 2 weeks after conception, but you're already out that first 2 weeks. Organogenesis happens 2 to 8 weeks post-conception, or if you think about it, you got to add 2 weeks for LMP dating. That's where it gets confusing too, because remember, when you read the literature, you got to compare embryologic age with last menstrual period aging, and it has to do with, once again, ovulation on day 14, conception a week later. So typically your embryologic age is going to be 2 or 3 weeks less than your LMP dating. So when we're talking 2 to 8 weeks post-conception, you'd be looking at 5 to 11 weeks from the LMP. Organogenesis occurs during this time period, and high dose radiation, 20 rads or more, can definitely cause significant organ damage. There's also at 8 to 15 weeks of gestational age, the central nervous system is sensitive at much lower doses of radiation, like 6 rads, where you can get actually measurable intellectual disability. And then finally, microcephaly is usually seen with 20 rads of exposure, and that is also the most sensitive during that time of brain development at 8 to 15 weeks estimated gestational age. once again, we're talking a significant amount of radiation when you think of a chest x-ray as 1/1000th of a rad. So, I mean, when you're talking 6 rads or 20 rads, you're talking somebody's basically had whole body radiation, CT scans, etc. And it's pretty rare in today's imaging modalities to get that high of radiation. The other thing is, if you're ever really concerned and you have a patient who's really concerned about the exposure her baby had to radiation, all of the radiology departments are required by law to document how much x-ray each patient has been exposed to, pregnant or not, as part of the ACR kind of standard. So like if the baby, let's say a mom had an upper and lower GI, didn't know she was pregnant, especially when you're dealing with fluoroscopy, you can ask the radiology department to actually give you the amount of dosimetry that the patient was exposed to, so you can calculate out the risk. And all you have to do is call the department, and there's a dosimetrist for each department. And we have one actually that's over radiation oncology as well. So we actually have 2. So now you can see IQ loss, and what they've said in this article, which is interesting, 25 points per 100 rads. But you can see, and that's at 8 to 15 weeks. However, if the baby's exposed to 25 rads, you can see IQ loss at 16 to 25 weeks. Now, once again, you're almost talking like a radiation accident or radiation exposure to get up to 100 rads. So a lot of this data comes out of like when they've had the nuclear reactors or over in Chernobyl and stuff like that. It is going to be extremely rare to get these kind of radiation exposures under a normal patient, under normal circumstances. However, the last point I think is the most important, and we've all heard this article, and I think Dr. Ernstberger and I have talked about this before on occasion, where the biggest concern we have when we expose early fetuses to radiation is the overall lifetime risk for leukemia. So any exposure to ionizing radiation in the womb of a fetus can increase the lifetime risk of leukemia by 2-fold. If you compound that with a family history, that is a significant risk, and that can be as low as 1 to 2 rads. And it is very realistic to get into the 1 or 2 rad range. So before any of the patients that I get consulted for to talk to them about radiation exposure, the first thing I do is ask them about a history of leukemia. And I tell them it is a 2-fold increased risk of leukemia, but you got to remember the overall baseline risk in a non-at-risk fetus is still very, very small. So once again, it's how you look at it. If you look at this article didn't quote the number per 1,000 or number per 10,000, but I always tell people, you got to remember statistics can be very misleading. So for example, just as an example, when we were using Desigen a lot for our birth control pills, and it came out that there was a 10 to 20-fold increased risk for DVTs if you use Desigen containing oral contraceptives. That sounds absolutely horrible, 10 to 20-fold increased risk. But what people didn't realize is the risk went from like 1 to 5 per 100,000 users of birth controls to 100 to 200 per 100,000 of birth control users, which is still a reasonable number, so it's not to be ignored. But people forget what the overall risk for complications and death from pregnancy are. So totally ignoring the fact that still only having a risk of 10 per 100,000 DVTs for using that type of birth control pill was still, probably 10-fold less than any complications you can have during your pregnancy. So once again, you just got to be careful what this 2-fold risk really means. And unfortunately, I didn't have time to look up what the baseline risk is like per 1,000, but it's still a very small risk. So the benefits are still going to outweigh the risk 99% of the time, and just keep that in mind. Now, the Radiologic Society of North America has come up with these guidelines and said basically there's going to be no deterministic effects with less than 100 milligray or 100 rads. There's going to be no 10 rads, I'm sorry, so you got to take that off. So that's 10 rads. There's no stochastic effect at less than 2 to 5 rads. So really the risk of leukemia is probably not even elevated until you get greater than 2 to 5 rads. Now, in the handout I gave you, and I'll go to it at the end because of screen sharing, Basically, it has a really nice table. I was afraid to copy it onto a slide because it would have been so small. Of course, on Zoom, it probably wouldn't have been as bad. But just for an example, a extremity, an X-ray of the cervical spine, let's say you have a patient in the ER with trauma, the amount of centigrade or milligray radiation to the fetus is less than 0.001 milligray. So that would be 0.0001 rads. So you can see how low of dose we're talking about. Now that's considered very low dose, less than 0.1 milligray. A good example for an abdominal X-ray. So if we're to order in an IVP, for example, an abdominal X-ray exposes the baby to 0.1 to 3.0 milligray. Now, the reason there's such a big variance there is it has to do with patient body weight, right? They're going to have to use a lot more ionizing radiation to go through a 350-pound patient than they are through a 70-pound patient. But basically, even in the worst case scenario of 3 milligray, you got to remember that's still just 0.3 rads. So if you did a single shot IVP on a patient because you were worried about a kidney stone, the overall radiation exposure is 0.3 rads, which is well below the 2 to 5 rads before you're going to get any stochastic effect. And then just as a last, like high dose, an abdominal CT or a pelvic CT does expose the patient to 1 to 5 rads. So if you do a pelvic CT on a pregnant patient with direct radiation exposure from the CT, that is a 1 to 5 rad exposure, which is basically going to get you close to this effect for leukemia. So before anybody gets an abdominal or a pelvic CT, we really have to have that talk. But then again, if you're worried that they have a ruptured appendix, before we had MRI, we really didn't have much of a choice because the surgeons weren't going to take them to surgery unless you had a CT. So you're in that catch-22. If you don't do the CT and they got a ruptured appendix, they're going to lose the pregnancy and they're going to miscarry. And that's what I tell them, because once you have a ruptured appendix, it's a 50% chance that they're going to have a miscarriage or go into preterm labor and deliver. And unfortunately, since I've been here in this hospital, I've delivered at least 3 babies I can recall in the ICU under 20 weeks after their ruptured appendix, even after their surgery because of the overall peritonitis, and basically deliver an 18-week pre-viable fetus in the ICU 12 hours after surgery. Now, of course, they're going to blame the surgery for the miscarriage, and the family will always try to sue your pants off. But the bottom line is once you have a ruptured appendix and you have gross pus in the abdomen, I tell them there's a 50 to 60% chance that you're going to lose the pregnancy, or if not lose the pregnancy, go into labor within 1 to 2 days because of the overall inflammatory response. And that's why it's important we don't let these people get into septic shock, or we don't let them get into an acute cholecystitis, or we don't let them get into a ruptured appendix or pyelonephritis where they're having neurosepsis, because once again, that 50% pretty much goes across the board for any peritoneal type infections. Gadolinium, basically don't give it. Most of the MRIs that we do, we don't need gadolinium to determine what we need. If you do, then you can talk it over with your radiologist, but I've never had a radiologist yet agree to give gadolinium, just so you know. Nuclear imaging, this is, when we used to do a lot of VQ scans for us old people. Now, I don't know the last time I've actually gotten a VQ scan because everybody just gets a spiral CT of the chest anymore, or a thin slice CT of the chest for pulmonary embolus. But basically, technetium-99m and xenon-133 are both safe during pregnancy. You just got to remember we can't use radioactive iodine during pregnancy because it crosses the placenta, it will get absorbed into the fetal thyroid and can cause thyroid failure in the newborn and in the baby as well. So absolutely, this is category X. So very few drugs that we have are category X, but this is one of them. If you want to look up what it says for category X drugs, just look up radioactive iodine 125. So that was interesting as well. Most cause less than 5 milligray. So remember that's 0.5 rads. And so we can use a VQ scan if we need it. You can use some bone scans if you need it. But I'll be honest, nowadays, I don't know that for pregnant age patients, we do very many nuclear studies. Now, once again, anesthesia becomes the other big concern. So first off, when you get called to the ER, how are we going to image them? How are we going to work them up? If you're a hospitalist doing wards, or if you're down at ER moonlighting, you know, the first concern you always have is, are we going to image them or not? And once again, you can always ask me to consult, and I can even do a virtual consult now, and I'm more than glad to talk to the patient. Now, if you do, on one last note before we move on, if they want you to sign a consent for radiologic procedures, you only have to sign that consent if you're doing direct ionizing radiation to the abdomen. You don't have to do it for an MRI. You don't have to do it for an ultrasound. You don't have to do it for a CT of the head. You don't have to do it for a CT of the chest. But because you saw how I told you how high the radiation is for an abdominal and pelvic CT, and it does increase that lifetime risk of leukemia for the baby, hypothetically, you will have to sign a consent as the ordering physician, consulting the patient to the risk and benefits of the procedure and what the potential lifelong risk for the baby are. And if you do not feel comfortable doing that, then I'm always available for a virtual consult, and then we can just sign it virtually with a witness in the room. So that's just something to consider. Now, the big concern during anesthesia is, you know, is it safe to do anesthesia during the first trimester? Should we delay until the second trimester, etc.? And the bottom line is basically, if you know a patient is pregnant, really there shouldn't be any issue with any of the anesthetic agents that we currently use during pregnancy. Now, anesthesia will still have a BF and basically not be happy about putting a first trimester patient under. But once again, delaying that surgery or treatment until the patient is extremely ill is what actually leads to more of the complications. Now, every drug does possess potential problems in some species. So what they basically do is when they look at this, there's some species at some dose that will show any drug that is not safe. And what I mean by that is, it was just for me to remember to tell you that when you look up now in the PDR, or whether you look it up on Hippocrates or one of those LexiMet or LexiComp, or, you know, any of those, they're basically going to talk about the MMR or MMD. And what the MMD is basically the mean human dose, or MHD, the mean mammalian dose. So like, for example, if you take a rat and you expose it to 50 times the normal dose concentration that a human will consume normally, it could be teratogenic. For example, saccharin would be a good example. Saccharin does cause liver cancer, there's no doubt about it. But in order for you to show a significant effect of saccharin causing liver cancer, you have to expose somebody to like 20 times. I'm making the number up, but it's like 20 times the normal dose, unless somebody's just bathing in saccharin. They shouldn't get liver cancer if they use it for their iced tea. But what they'll do is they'll take mice and they'll basically expose it to 1 times human dose, 10 times human dose, 100 times human dose, and then they can say, if there's no risk of teratogenesis at 100 times the human dose, and a lot of times they quit at 20 times the human dose because they figure that's not realistic, then they'll say there is no risk for hypothetically human or animal models. But what we used to get into with the old ABCD system was basically B was, it's been shown to be harmful in animal models, but no human models. C was, it's harmful in animal models and may be harmful in some human models. And then D would be your basically, it's been shown to be harmful in human models. And then X was, of course, never to be used in pregnancy because the benefits don't outweigh the risk, which are very few of those. And of course, the big famous one would be thalidomide or radioactive iodine. I mean, there's very few category X drugs. The other thing is the commonly available agents, when you look at their normal dosing, all are safe. And specifically, when you look at our current neuromuscular blocking agents, there's minimal placental transfer. And people forget we actually give them, and it's the coolest thing ever, and it's kind of frightening, where we would give intermuscular through the womb into the leg muscle, or usually the leg muscle of a fetus, if we're trying to do fetal surgery, or if we're doing a chordocentesis and it's really early and we're afraid the baby's going to pull the needle out of the umbilical cord. Basically, we'll drop that needle into the baby's leg and paralyze it and it'll last about 4 to 6 hours, and the baby just is floating in there, and it's kind of spooky, really. But then it will wear off, because you got to remember the baby is hooked to its life support system, so it really doesn't have to breathe, it doesn't have to move, it doesn't have to do anything technically for survival. So it just looks kind of spooky when the baby's just floating in the womb, but it's alive. The only thing that would be concerning, and that's why when you've seen us do emergency C-sections, or if we have to do a general anesthetic because we can't get a spinal, is that because it does cross somewhat to the placenta, you can't see neonatal depression after delivery. So you should always have a reversing agent available in case the baby doesn't arouse easily after surgery. Early pregnancy loss, there seems to be a small but measurable increase in that, but that's also been very criticized lately as being maybe overinflated. Once again, most people don't check a pregnancy test super early in pregnancy because they're not concerned, but when you come to the ER and you're under 60 years old, and for any complaint, you're going to get a pregnancy test. So if you have a ruptured appendix and you were 2 to 3 weeks pregnant, you don't know if there's going to be a baseline risk of miscarriage in that pregnancy or not. But clearly, if they're having an acute illness and you have to operate, there's not much choice. Basically, the new dogma is there should not be any delay in surgery, even in the first trimester, especially for emergent surgeries, obviously. But even the ones that, where we get into trouble is, I've seen lawsuits before that I've tried to help defend is patient comes in with vague abdominal pain, nausea, and vomiting in pregnancy, and she's 8 weeks pregnant. Show me an 8-week pregnant patient anywhere that doesn't have some nausea and vomiting. I mean, remember, nausea and vomiting in pregnancy is in 80% of our patients. Hyperemesis may only be 10 to 15%, but there is 80% have nausea and vomiting or more. So when you have somebody come in with, anorexia, nausea and vomiting, some abdominal pain, etc., it's really hard when they're not febrile and their white count's only mildly elevated. Well, you think they might have an appendix, but you're not sure. They're at the right age group. So we just kind of sit on them. Well, the problem is they'll come to the ER 3, 4, 5 times being worked up for hyperemesis without anybody deciding to actually scan her belly. And lo and behold, she'll come in that 5th time with a ruptured appendix, a temperature of 103, a white count of 30,000, obviously a medical school diagnosis at that point. But by then it's too late, because once that appendix ruptures and they become septic, then they're going to miscarry that pregnancy. So that's the hard part. Now, early on pregnancies, and this is what, we quote a 15% risk of miscarriage, but that's a little underinflated because of this reason. When a patient has a positive pregnancy test, until you've documented an intrauterine heartbeat, there's actually a 25 to 30% risk that she could miscarry before she's ever documented to have an intrauterine pregnancy that's viable. And I think people forget that. What you hear me tell patients when you guys rotate with me is 15 to 25% risk of baseline miscarriage. Once you have a heartbeat, or once you see a pregnancy recognized, and usually we mean heartbeat, that risk drops to 8 to 10%. And there's a 10% risk of miscarriage after surgery, but that mirrors the risk of first trimester miscarriage anyway. So the question is, how much of it is above the 8% to the 10%? And once again, it's a small but measurable risk, but still not enough to want to delay surgery if it's clearly indicated. Now, the problem is how do we define clearly indicated? And that's where the surgeons sometimes can be very reluctant to operate. And unfortunately, if the surgeons don't operate and the patient miscarries, you're going to be the one on the hook, not the surgeon, which is totally buckus, but that's the way it works. So my rule of thumb is if I don't have surgeons here that will operate, I will transfer them down to Indianapolis and have the surgeons down there with the MFM team down there with all the academic gurus saying, no, this girl, if I truly think she needs surgery, but I can't get anybody here to operate on her, like a cholecystectomy or a appendectomy, I will send them to Indianapolis to be evaluated versus waiting another week or two if I'm really that concerned. The good news is with the newer surgeons that we've had, and some of the ones that absolutely refuse to operate on pregnant women are now retired or moved on. So the problem we're having now is not nearly as bad as it was 10 to 15 years ago. And Dr. Bunch probably remembers when she was a resident, you know, basically, unless you were on your deathbed, you weren't going to get a surgeon to operate, because they were trained at the time as you only operate on pregnant women as a last resort, which was an absolute horrible dogma to live by. Preterm birth versus preterm contractions. Obviously, there's a higher risk of preterm birth and preterm contractions in the third trimester. Once again, all the studies are very poorly controlled, poorly run, poorly documented. So it's just more or less, a lot of them are case reports or case series. Really no good studies have been done. Many were preterm contractions, not in labor. So what I mean by that is, it's not uncommon if I fill a woman's belly up with gas and watch her on labor and delivery after she goes to surgery, and I've been pushing around on her uterus and we've been mashing things around. The uterus isn't happy. The uterus is going to contract. But what we need to do is, once again, when I kind of argue with you guys, why aren't you doing a baseline cervical check when she gets to labor and delivery? As soon as one of those patients come up from labor or from the OR, if they're contracting, you want to do a baseline cervical either length, or you want to do a digital exam is adequate to make sure you document the cervical status when they get to the floor. Then if they continue to contract over 1 to 2 hours and you recheck them, have they made cervical change or not, right? So that's the difference between preterm labor and preterm contractions, is whether or not they're making cervical change. And then ultimately, most of them are preterm contractions. The beautiful thing that I like to do, and you guys have seen me do this, is after they've had their appendectomy or their cholecystectomy and they're less than 32 weeks pregnant, what do I usually like to give them for the first 24 hours after surgery? Well, I like to give them Toradol. One, it's very effective for postoperative pain management, but it's also an effective tocolytic agent from the standpoint it's going to stop their contractions. And I'm stopping the contractions not because preterm contractions are a problem, but the problem I see is everybody wants to overtreat preterm contractions. And I come in the next morning and the next thing I know, the patient's on MAG, the patient's gotten steroids, or most of the time they're pre-viable. So they're on 4 grams of MAG, they can't move. You know, and really the whole bottom line was that they were just the normal preterm contractions that you would expect. And then obviously, I've discussed multiple slides, the severity of illness increases the preterm birth rate. So obviously if you become septic or if you have a ruptured appendix, etc. And it's all due to the inflammatory response. Now, the big question also we get asked, and actually this came up in one of our division meetings, which I thought was interesting, was, do we do intrapartum or intraoperative fetal heart rate monitoring? And almost always the answer is no. And the reason the answer is no is, one is a lot of times it's just not technically possible. How am I going to monitor the baby's heart rate during the middle of an abdominal surgery? So it's like nearly impossible unless you get gown up and get surgical sleeves, and we do a direct measurement of the heart rate on the uterus. But the bottom line is, most of the surgeries, as long as the mother's doing well, the baby's going to do well. The scary part is, if you do biophysical profiles, the baby's going to fail because it's not moving, it's not doing anything, because it's paralyzed, especially in the longer cases. The bigger concern is, where it does make sense somewhat, is during cardiothoracic surgery or CV surgery, for 2 reasons. Number one, and we'll talk about this on another slide, so I won't belabor it, but basically, one, they're in the chest and not in the abdomen, so we can actually put the baby on the monitor relatively easily and keep them on the monitor while they're on perfusion. And number two is, it actually does help the perfusionists know if they need to be more concerned, because they use the fetal heart rate as kind of like their internal pulse oximetry. So, and we'll get to that later. Now, the 2 main questions to ask about intraoperative heart rate monitoring would be, number one is there a significant risk of maternal hypotension? So if we're worried that the mom's going to become severely hypotensive, for example, during a trauma, and let's say she has a lacerated aorta. Well, first off, 9 times out of 10, the ones I've seen like that in Detroit, we were doing a perimortem C-section already if they were viable. And if they weren't viable, it didn't matter because there wasn't anything you could do. So the other thing you got to ask yourself the question is it feasible to monitor the patient? Because can you intervene and do anything? Well, in the case of the CV surgery, you can improve her oxygenation. And that's the argument, is you want to improve mom's oxygenation status. But if you keep mom's oxygenated status adequate, then there really shouldn't be an issue. And then the other question is are you willing to deliver the fetus? Because do you want to be watching a horrid heart rate die on the monitor at 18 weeks gestation, where the only thing you can do is intrauterine resuscitation? And if those measures have failed, then are you willing to deliver the baby? Now, the most common surgeries for neurosurgery, so the two specific things that they talk about are neurosurgery and CV surgery. And the reason being is we all are pretty comfortable with appendectomies and cholecystectomies and what to do with them, and we will touch on them briefly. But the most common surgeries for neurosurgery are brain tumors, intracranial hemorrhage, traumatic brain injuries, and spinal surgery. And as it would make sense, they're far away from the belly, but the problem is positioning and what is the best position for the mom. You can lay the mom on their abdomen. We've actually held them up with pillows, kept them in the prone position. Obviously, supine position is beneficial, but if you have to be in a prone position, you can make it work, but you just have to be careful about compression of the vena cava and things like that. But it can be done, and that would be another case where you may want to do occasional intermittent heart rate monitoring just to make sure you have a normal heart rate, but certainly no continuous monitoring would be recommended. The use of mannitol is real common in neurosurgery, and mannitol helps to decrease the intracranial pressure, and it's been shown to be acceptable but not desirable in pregnancy. So once again, it becomes a risk versus benefits. Mannitol can cause oligohydramnios and cause decrease in fluid, kind of similar to other diuretics, but for whatever reason, mannitol seems to be safe, even though it doesn't cross the placenta, but we try to avoid it if at all possible. But once again, the thing I tell the neurosurgeons are, okay, this patient's not pregnant. What would you do? If we have a traumatic brain injury and the lady's going to die from uncal herniation because she's got so much intracranial pressure, she's going to, herniate her cerebellum, it's probably good to use mannitol if the screw hasn't worked or the bolt hasn't worked, because if not, she's going to die anyway. So sometimes, you got to raise the benefits versus the risk as far as mom goes versus fetus. And once again, the hard part of our job, right? The other thing to note is during hypothermia, so some of these cases are done under hypothermia, especially CV surgery, as we'll see later. Fetal bradycardia is a response to hypothermia, just like fetal tachycardia is a response to hyperthermia. So it is not uncommon to see a fetal heart rate in the 60s to 80s when the mom is chilled down, and you should not go blazing in there with scalpels and doing a stat C-section on a baby that's chilled down to 60 or 80 degrees during the surgery, because that's a normal diving seal reflex. Remember, once again, with the diving seals, not only are they going under and holding their breath and slowing their heart rate, but they're also being super chilled in the Arctic waters. So a lot of times their heart rate will also slow down because of the hypothermia. And then there's hypotensive techniques. If the surgery requires like hyperventilation or different hypotensive techniques where the only option for the brain surgery is hypotension, and I don't know those off the top of my hand, but they are significant enough because of concern of placental insufficiency to the baby and the increased risk for stillbirth that they would consider early delivery regardless of gestational age, because prematurity is still a better alternative than hypoxic brain injury. So you take your chances if they're above viability. If they're below viability, there's nothing you can do but just counsel the parents that hopefully the baby will pull through, and it's the best we could do in attempts to save the mom. So anyway, the mitral or aortic valve decompensation is the biggest reason why we see cardiothoracic surgery. So they have a blown mitral or aortic valve. Once again, you do not want to delay surgery regardless of gestational age. These moms get put on cardiopulmonary bypass. You want to minimize the amount of hypothermia if possible. It's important to know that for the perfusionist, they use high flow, high pressure perfusion. And the biggest, most important thing that I took out of this, and it was actually in a question, was maternal acid base monitoring is very important, and that'll be on the next slide. And then fetal heart tones actually can be beneficial to the perfusionist, because if the fetal heart tones aren't looking reassuring, the perfusionist can do all kinds of tweaks to their perfusion machine to try to improve that. Now, the pneumoperitoneum during laparoscopic abdominal surgery, basically you want to keep the pressure under 15 millimeters, which is standard. And under the use studies, they showed that hypercapnia can lead to fetal hypercapnia, fetal tachycardia, and fetal hypertension. Safe at later gestational ages. So the other thing that's changed in laparoscopic surgery is we used to say, well, you can't get a gallbladder or an appendix done laparoscopically above 20 weeks gestation. Well, now you have to paint my face red because we've had some 32-week appendectomies or 32-week cholecystectomies. So they're doing an open Hassan trocar placement. And basically, if they think they can sneak a scope in, the surgeons now are gutsy enough and realize that the babies aren't going to go into preterm labor, that I've seen them do it as late as 32 to 34 weeks. If I have somebody beyond 34 weeks that really needs emergent surgery, then a lot of times it's probably smarter just to deliver the patient at that point. Once you're beyond 34 weeks, give them steroids and deliver them if you have time. So for the discussion, there's no support for early pregnancy loss or preterm delivery. Diagnostic procedures are safe almost across the board. The only thing to concern yourself with is abdominal and pelvic CTs. And even then, if they know they're pregnant, a lot of times they'll lower the dosing. Anesthesia is safe throughout pregnancy. Obviously, you want to avoid any elective surgeries. The neurosurgery and CV surgeries have the greatest risk because of inherent issues in the way they do their surgery and the way it affects the fetus. There's a multidisciplinary team approach. When we have a surgical patient, you know, we should get the nurses involved, the anesthesia involved, the doctors involved, everybody should be involved. And the bottom line is, once again, and I've given this lecture for 20 years now, and it's still the same old, the delay in surgery leads to poor outcomes and why pregnant women do worse than non-pregnant women, not due to pregnancy itself, but due to the delay in surgery. So, any questions before we move on to the 4 questions? So I have 4 questions to see if I got the points across to you guys.
Hey, Dr. Landwehr, this is
Yes. Coop, what's up?
Do you ever have anyone further along, like 3rd trimester, that you'll go in and do a C-section along with another surgery, or are they always spaced out temporarily?
It depends, but normally no, we won't because of infections and things like that. I know the other thing that people ask sometimes is if we're going to do a cholecystectomy, probably the other way around. If I know somebody has to have an emergency cholecystectomy at 36 weeks because they've perforated their gallbladder, which is extremely rare nowadays because of our imaging and stuff. But let's say somebody has a porcelain gallbladder or somebody has a perforated appendix at 36 weeks and we have to go in. Yeah, we would go ahead and do the C-sections with the surgeons. The problem is the poor soul is going to get a top to bottom sternum to pubis, you know, up and down laparotomy incision, which is always lovely for a 22-year-old patient to have a stern to stern incision. But we do what we have to do. The flip side, though, is if we're doing a C-section at 38 weeks or 39 weeks for somebody with like an acute cholecystectomy, but not really subacute, then they'll try to wait 2 or 3 days after the C-section and then go in and try to do them laparoscopically because it's still less comorbidities than if we went ahead and tried to do it at the time of C-section. Plus, as you can imagine, we can't reach the gallbladder through a fan and steel incision. Not that we can't do an up and down incision, but the healing from an up and down incision is very bad compared to a fan and steel and a laparoscopic incision. So when I explain it to the patients, their options are, and I draw a line from their sternum to their pubis versus a bikini incision and then 3 bullet holes or 4 bullet holes afterwards. It's extremely rare that I have somebody ask me to do open surgery so they can do them at the same time. Does that make sense?
Yes, thank you.
You're welcome. Any other questions from abroad?
I have a question. Can you hear me?
Yeah.
Okay. So this is Kristen. With patients who have known placental insufficiency, how does that affect your management of things? To me, it kind of sounds like if it's an emergent surgery, you do it. But does that affect management of even like scans?
I mean, so if they have underlying, if I couldn't hardly, I heard some of it, but if I understand you right, if we already have underlying placental insufficiency, like a baby with intrauterine growth restriction, is that what you're saying? Is that going to affect how? Yeah, absolutely. And that's the most common time I see that, honestly, is during cardiovascular disease, and usually in my elderly patients, you know, over 40. Because let's face it, those are the ones a lot of times we have the valvular disease. You can have some congenital heart disease in teenagers or 20-somethings, but almost all of the cardiothoracic or neurosurgery that I see that wasn't like congenital wind up being at a later age. And a lot of the ones that are in the middle age are because of drug use. So we'll see them blow their mitral valve or their aortic valve because of vegetations or something. And yeah, if we have a severely growth restricted baby that's already severe IUGR, and they're not going to tolerate perfusion or anything, if they're above viability, which is usually when you're going to diagnose IUGR anyway, we probably would go ahead and deliver them because the baby wouldn't survive surgery. So yeah, that is definitely going to play into the role. And if, especially if we have like marginal Dopplers or something that makes us think that that placenta is not super healthy anyway, that would be a discussion I would have with the parents, that it's probably better to deliver her before the surgery than have to do a crash section during a surgery. Can you imagine doing a crash C-section during an open heart surgery? I don't think that would be probably very conducive to either patient. You know what I mean? So,
Yeah.
so we just have to play that by ear. But yeah, that's a great question. Fortunately, that doesn't come up all that often because a lot of the appies and choles usually I see during the first and second trimester. So we usually haven't seen significant growth restriction by then. Okay.
And what about imaging? Would that change what you do for imaging?
No. So when it comes to imaging, growth restriction wouldn't have anything to do with imaging. I mean, you are concerned, but usually, once again, by the time you're going to image somebody with growth restriction, you're in the third trimester. So by then, if you think about the size of the placenta, if you are going to get some placental effect from radiation, hopefully what placenta's left is enough to absorb it. I mean, yeah, I wouldn't be happy about it, but I think once again, why are you actually wanting to do the imaging modality? Is it going to really change your management? Or is it going to just buff the chart for the surgeons? You know, I don't know. So that's a hard question, but it would not necessarily, that part would not necessarily change my decision. Okay.
Thank you.
All right, welcome. So 4 real quick questions. So these were my board questions. Which of the following is the most common type of non-obstetric surgery during pregnancy? That was pretty straightforward. So GI, obviously. So see, sometimes we get bunny questions too. So I thought that one was pretty easy. Second one, a patient at 28 weeks gestation is a restrained driver in a high-speed motor vehicle accident and being evaluated in a trauma bay. Which of the following has a higher expected fetal radiation exposure? Well, I told you a low dose radiation exposure cervical spine makes sense because that's just going to be basically an X-ray of the spine. Now, this is pretty funny. Low dose perfusion scintigraphy, I would think, would expose the baby to high dose radiation, right? No. So even if you have no idea, you would just count that off because it says low dose. That's what I would do. And then so you're left with pelvic MRI or abdominal CT. Well, since pelvic MRI has no radiation exposure, I guess the answer would be abdominal CT. Hello. So pretty easy as well. Intraoperative maternal hypotension has what effect on the pregnancy? Early reduction of fetal perfusion, poor encephalic cyst development, long-term intellectual disability, or placental abruption. Well, right off the bat, placental abruption, no. Do you guys know what a poor encephalic cyst is? So a poor encephalic cyst is in the brain when there's damage to brain tissue that leads to necrosis. And basically it's a empty abscess cavity that develops in the fetal brain after an in utero stroke. But it's not usually due to radiation exposure. It would be due to like an in utero stroke event. And you see these holes in the fetal brain. It's actually very sad because those babies usually have very poor prognosis. I've seen it in diabetics before where the baby's had an in utero stroke. But a poor encephalic cyst development is usually vascular and not due to radiation or hypotension. So more of a stroke beyond hypotension. And then long-term intellectual disability, if you look at what we were talking about here, that would be like CP or some of those. But actually, so that's kind of where I was like, is it A or C? And actually the answer is simply A. So you get a reduction in fetal perfusion. So that's why it's important to prevent hypotension or hypoxia during surgery, because you will get a reduction in fetal perfusion initially. And, you know, if that goes on for a prolonged period of time, then it can lead to other complications. But that's it. So questions from you guys? Anything I can answer for you on that? I think it's pretty straightforward. I did send you the articles. Amy sent you out the article. So, I think that's a nice little card to just make reference to. The other thing is since we live on Google time these days, right? One of the nice things, thanks for the hand clap. Oh, sorry, one last question. This is one you'll have all the time. 26-year-old at 18 weeks of gestation undergoes an aortic valve replacement and requires bypass. Which of the following should be considered? Well, I told you it's high flow, high pressure, so that one's wrong. Maternal acid-base assessment should be performed. Ring, ding, ding, ding. Fetal monitoring will not assist, here's the key, not assist in monitoring pump perfusion parameters. That is not true. So this is one of the only surgeries where fetal monitoring may be beneficial to help assist in perfusion parameters. And maternal hyperthermia improves maternal and fetal outcomes. Well, that's duh. Have you ever seen them heat up a heart patient to speed up the heart during surgery? I don't think so. Because the first thing I remember when I saw an open heart surgery was I couldn't understand why the nurse was going out and getting 17 buckets of ice. I thought, what the hell, is it already time for cocktails? But nope, we just dumped it all into the guy's chest and stopped the heart with just hypothermia, which was impressive to me, that you could stop the freaking heart with just ice water, which was pretty frightening. But once again, leading back to the rule of thumb when we used to get floaters out of the Detroit River, you can't be cold and dead, right? You can only be warm and dead. You guys have heard that before, right? It's kind of a sick phrase, but it is true. If somebody comes out of the water and they're 20 degrees, Fahrenheit, their heart could have stopped because of the hypothermia. So that's why you got to be warm and dead. And sometimes it takes us 6 hours to warm these people up before we could technically pronounce them dead. We'd even do intraperitoneal gavage, trying to warm them up with warm water just so it wouldn't take like all day, because with no perfusion and no blood pressure or anything, they'd still be cold 12 hours after they got brought in. So we would just start pumping them with intraperitoneal gavage to just try to warm them up. But anyway, that's a pretty good question. So with that in mind, if you guys have any other questions, the only other thing I was going to say is I think what I've been doing lately for my consults, which I thought was kind of interesting, is I've been going to Google, Dr. Google, and when somebody asks me a question, a lot of times I'll call Dr. Google and see what he has to say, because that's what the patients are looking up. So I think it's interesting sometimes when you put in Google searches, now I'm kind of seeing what winds up coming up on the top. So we'll just put in there, radiation exposure to fetus from, oh, I can't spell either. You like that? My keyboard's obviously working like stupid overtime here. Yeah, I'll blame it on the keyboard and all what it's doing. From X-ray to fetus. See, here we go, double T. What is wrong with my wireless keyboard? That's the problem with wireless keyboards. See, it just did it again. Great. Guess I'm going to be resetting this keyboard or getting rid of it. Huh. So I don't know, it's going to give us what we want. Radiation risk from medical imaging. So, and a lot of times they'll give you the tables, so you can look up the tables if you're on call. See, here you go again. So, bone density, X-ray chest, see 0.1. So once again, this is actually, they're using MSV, which I don't even know what MSV is. That's a new one. Oh, sievert units and millisievert units. Okay. That's on Geiger counters. Okay, great. That's something we use all the time. But anyway, 0.1 is what I remember for RADs. So it's going to be about the same. So average effective dose, 0.1. Here's a CT of the pelvis. See, there's your 6 RADs. CT of the abdomen, 8 RADs. Whole body CT is variable, but it could be 20 or more. So this is where, once again, a CT colonoscopy would be 10. So you can look up these tables just by Googling it. And then, you know, you can Google again, like fetal exposure, or you can look on WebMD has it too. So anyway, just something food for thought. Okay, guys, thanks so much. Time's up. And you guys have a good month and welcome to 2021. Get your COVID vaccines and everybody stay safe. To answer a question Mel had, just for you guys to know, do I have to be consulted on every COVID positive patient as an outpatient, especially when they're asymptomatic? The answer is no. Currently, I'm just required to consult on inpatients that are COVID positive. But if you have any questions regarding the guidelines that the system put out, or if you're not sure if a patient should be admitted, remember they can rapidly deteriorate in pregnancy, even if they're asymptomatic. My rule of thumb is if somebody got asymptomatic and they're COVID positive, are they really asymptomatic? Because young people can compensate well. My rule of thumb is for my office is I bring them in at the end of the day when I can isolate them and check a pulse ox on them. Because remember, you want their pulse ox to be above 95% on room air or at exercise. So I put a little finger, we got a little finger pulse ox in our office now, and I'll walk them around the exam room a couple times. And as long as their O2 sats above 95%, I can document, lungs are clear, patient has 95% room air oxygen at exertion, obviously minimal exertion, and was given precautions, and then I let them go home. Some people say, well, should you even bring them into your office? I think it's gestational age dependent. If they're in the first or second trimester, probably not a big concern, because what are you going to do anyway? Obviously, you don't want them to have signs or symptoms of COVID, then they'll have to come to the ER. But if you're in your third trimester, because they're short of breath all the time anyway, that's the objective way I've been evaluating them to make sure their shortness of breath is due to their 35-week pregnancy pushing up against their diaphragm, and not that they're sat in 88%. Does that sound reasonable, Jen? What are you guys doing in your clinic at FMRC when you have a positive, like COVID test when they're pregnant, but they otherwise don't have symptoms? Just give them precautions and then tell them to call if they have any symptoms.
Yeah, that's kind of what we're doing, Joe, is you know.
Oh, sorry, Mel. Didn't see it.
Looking at their risk factors. I think getting a pulse ox is a great idea. And we've even offered that in the, like, drive up pulse ox option.
Right.
Obviously we can't walk them that way as easily, but
yeah, but I mean, if they're 99 or 100% on room air,
right.
most of them are, it's not a big deal.
Right.
I only walk them if I'm concerned, but if, like, you know, they come in, and we've been doing pulse oxes on every patient now.
Right.
Just as a baseline, because, you know,
and some patients are even purchasing a pulse ox, you know, just because of risks and stuff. And those they're I mean, you can buy those, and so
I mean, they're pretty cheap nowadays. It's pretty funny how cheap they are, because all these athletes.
So that's not a bad idea for some of them, especially the pregnant ones. So
yeah, and I mean, and if they seem reliable, you know, private practice patients are somewhat different than the clinic patients, I think, and we definitely don't want to expose the clinic if somebody really is
right.
You know,
that's our big thing. They have to talk
right.
to us about bringing them in. Yeah.
Right. So they talk to me, and then, you know, we do a case by case kind of evaluation. But if there's any question, you know, say, well, I'm not really too short of breath, you know, I'm like, bring her in.
Yeah.
You know, it's like the asthma patients, right?
Right.
You know, if they can't complete a sentence and they say, well, they're kind of short of breath, but they can't even talk the complete sentence, I think they probably need evaluated. If they're talking normal, they have no symptoms, and I give them the guidelines, I think that's pretty good. I agree. Yeah. Okay, perfect.
Sounds good. Thank you. Great presentation.
Hey, thank you guys. Appreciate it. If you have any questions, let me know. All right, guys, have a great day.